Hi, everybody. I hope that everyone can hear me okay. We're launching this online journal club for the very first time tonight, and we'd like to thank CMSC for providing us the opportunity to do this. This is the Advanced Perspectives in MS, a virtual journal club series for the advanced practice multiple sclerosis clinician. What we wanted to do is have this in the spirit of a journal club, so we've sent out the article, and hopefully folks have been able to download that, read it, and digest it. We've had some really great comments and questions submitted to the online thread already, and so we'll try to address those as we go along this evening. What I'm going to do is basically go through a couple of housekeeping slides and talk a little bit about what we're going to do here tonight, and then we're going to open it up. So just like a journal club, if we were all sitting around the same table after reading an article and having a discussion about it, we're going to open it up. And so there are a couple of ways that folks can chime in. Certainly one is to ask questions through the online portal, through the chat box, or we will be opening up the phone line so folks can talk freely as well. When we do open up the lines, though, I would ask folks to, if you're not speaking at the time, to put your mute on to eliminate any potential background noise. So today's article is the very first article that we had selected. The title is Stabilization Without Rituximab After Disease Activation in an Alemtuzumab-Treated Patient with Multiple Sclerosis in a Literature Review. And this was in the IJMSC recently, and we chose this article because we thought that it would bring up a couple of really good discussion points, and we are very pleased to have our authors online with us this evening as well. Chantal Kahovic and Dr. Michael Levin from the Saskatoon Multiple Sclerosis Clinic, our neighbors to the north in Saskatoon, Canada. I will be your moderator this evening. I'm Brian Walker, and I'm at the Duke University Division of MS and Neuroimmunology. We have our session faculty and disclosures listed up here for your review as well. Our authors are very distinguished, and we're very, very pleased to have them with us this evening to address questions that folks might have with regard to the article itself or with regard to the case that they had presented in the article. We would like to note that the program tonight has multiple commercial support, and that this has been granted to us through the Center for MS, CMSC. Now, our objectives is, what we want to do is have a series of these articles that we can come together and discuss as an online journal club. Maybe about every other month we'll try to do this. And what we want to do is to identify the latest research and clinical information available in the literature with regard to MS diagnosis, treatment, and monitoring. Now, our colleagues at CMSC were really, really great in being able to provide us continuing education for this. With their joint accreditation, we are able to confer continuing education for a number of different disciplines as well. So at the end, there'll be a slide with instructions on how to get this CME or CE credit for it. If you've registered for the program tonight, you will be getting an email from CMSC with directions on how to claim that credit. Now, as I stated, this was a recent article that was published in IJMSC. And I'm just going to read the abstract here to just get us started. And after I do that, I'm going to ask that we open it up to the folks who are online and who are dialed in this evening as well. And then we'll just have a discussion. So the abstract is that there has been an increasing number of reports describing B-cell associated disease activation in patients with MS after alemtuzumab treatment. Herein, 4.5 months after a first alemtuzumab infusion, a 33-year-old female patient had altered gait and vision loss associated with GAD enhancement of the optic nerves and chiasm on MRI of the brain. The patient's blood work showed normal B-cell counts concurrent with abnormally low T-cell counts. The patient was stabilized after receiving steroids and prolonged plex without the use of rituximab. The case report adds to the growing body of literature of B-cell-associated disease activation after alemtuzumab infusion and provides a therapeutic strategy to stabilize patients when rituximab is not readily available or if contraindications to its use occur. So at this point, and I have a couple of other slides to sort of support the article, so we can flip back and forth on those as questions come up. But at this point, what I'd like to do is just open it up to everybody who's on to discuss the article and open it up to any other questions that folks might have.
Thank you. One moment, please. All lines are now live.
Don't everybody talk at once.
Hey, Brian, this is John Kramer. How are you?
Good, John. How are you?
I'm good. Hey, I was wondering if one or both of the authors were on the line at the same time with us. I know that had been a potential opportunity moving into this evening's journal club.
Yeah, we're both here.
They are.
Oh, great. Hello. Thanks so much for putting together this case report. This is a great case. I was curious if there was any opportunity to talk about the optic chiasm enhancement and what your thoughts were on that particular finding on MRI in this patient who clearly looks, based on these films and the history, looks like a patient who has multiple sclerosis, but the rare involvement of the optic chiasm in an MS patient. I'm just curious, what are your thoughts on that?
Yeah, no, it's a great question, and we've gotten similar questions. I don't know if it was from you or from others about, could this be a form of NMO? Again, like a lot of us, we picked up the patient from the private sector around here and kind of got her midstream, and we're trying to get those records to see if those titers were sent. We did not send them. We're happy to. I think it's a good idea. She had what was thought to be, or what we think still is, relapse-remitting MS. It's been fairly aggressive with her. It started in her late teens, as described in the case, and she's been on a number of medications. She had an optic neuritis in the past. It's never been bilateral until this event. And as far as we can tell by MRI, it's never involved the optic chiasm. So we're certainly open to the possibility that this is a form of NMO. And after getting the emails, we're happy to send those titers and get back to people.
Interesting. Thank you.
Yeah. Again, in the supplement, her MRIs look more like MS than NMO, but still, it's certainly worthwhile following up that way.
So one question I had, this is Brian, was the history of DMTs that the patient was on previously. You had mentioned that she was on natalizumab, but was discontinued for a positive anti-JC virus index. Do you happen to know how long she was on natalizumab for?
A long time. We were just looking at that when you came out. It
was approximately 7 years that she was on it.
Mm-hmm. Oh, really? Okay.
Yeah. And she was fairly stable on natalizumab before her titer turned positive. And again, the switch was made in the hospital before we picked her up. The switch to alemtuzumab after a multifocal relapse.
Do you know, was she treated with steroids initially before she received her initial round of alemtuzumab?
She was, yeah. She was, so she was taken off natalizumab. Again, I think a lot of it experienced either increased relapses afterwards or rebound, however you want to describe it. She was admitted to the hospital. She got steroids. She didn't get plasma exchange. And I believe in the hospital, did she get steroids before?
She did. She got steroids, yeah.
With that hospitalization, she got steroids and her first dose of alemtuzumab.
Okay.
Hi,
Do
this
you
is
both-
Paula. So can you clarify that last part? So did she get the steroids at the time of having the relapse, or did she get steroids 2 months after she stopped natalizumab?
She got the steroids at the time of relapse.
At the time of relapse.
Shortly after the Tysabri continued, yeah, before she started the alemtuzumab.
But the Tysabri was discontinued, I thought, 4 months prior to this relapse.
Yeah, her Tysabri was discontinued in February, and she relapsed in about April and was hospitalized at that time, and got steroids in April, and started the alemtuzumab in May.
Okay.
Geez, I don't know about y'all, but I often get really anxious when I've had a patient either transitioning off of natalizumab or on natalizumab who's presenting with cognitive changes. That sort of gets me a little concerned right off the bat.
Yeah, I mean, with reading this, the first thing I thought of with cognitive changes post-natalizumab was, is any concern of an infectious process or PML, but her imaging findings didn't look concerning for that, and now hearing that she's been on it for 7 years, yikes.
Yeah, fair enough. Again, I forget the first time we saw her after that hospitalization, but certainly in the acute phase there would be concern of that. And then when we picked her up, she was back to baseline.
We saw her in June.
Yeah, and she was back to her baseline cognitively. I don't know if the hospital team sent CSF for JC virus DNA or not. We could dig into the chart and find out.
Hey, this is John Kramer. So obviously you both had not started caring for her yet, but I'm curious as to why perhaps she had been off of natalizumab for 4 months before coming into the hospital with this bad relapse. What are your thoughts on that? Did she give any insights as to why there's been such a long pause with therapy?
No. At the time, we were not her caregivers. No one likes to point fingers, but the fact is we were not her caregivers, and all of that happened before we picked her up in the clinic. I don't know whether her previous neurologist wasn't assertive enough, or there was a misunderstanding. But it's concerning, and I've seen this before. And 3 to 9 months after stopping natalizumab is pretty much when it happens. And she did have a pretty severe relapse then. So I don't have a good explanation for that.
Sure. Thank you.
I was just going to update you as well. She did have a lumbar puncture on admission to hospital with that relapse.
That brings up a really good question, and I don't know the answer to it because I don't think that there really is good consensus as to it. But, how long do folks wait if someone seroconverts to a positive anti-JC index on natalizumab? How long do you wait before switching them over to another DMT? Granted, it's going to, I guess, depend on, what DMT you're transitioning to, but what do people think about that? How long is long enough to say transition to either alemtuzumab or a B-cell depleting therapy? What do folks generally do or think?
Brian, this is Paula. What we've tried to do, especially if they're going to a B-cell depleter, it's a little bit difficult because of insurance, but we try, when they're due for their next 4-week infusion, we try to have them starting on the new drug at that time.
Hey, this is Jennifer Smith, PA. Sorry, I think I'm coming a little late to the conversation, but to answer your question, yeah, we do the same. If we're transitioning off of Tysabri for JC-positive folks, whether it be to ocrelizumab or rituximab, one of those. Typically, we try to do about 4 weeks, 6 weeks max, and we typically do an MRI the week before they start or the week that they start either the ocrelizumab or rituximab, just to make sure that there aren't any possible signs of PML before they get on therapy, and then we kind of repeat MRIs usually at the 6-month mark, sometimes 3 months after they've started treatment, just depending on what's going on. But I am so sorry, I'm coming late into this, and so this may have already been discussed, but the plasma exchange, I was noticing it was 9 plasma exchanges over 6 weeks. And so I was just kind of wondering, normally for us, when we do a plasma exchange protocol, we do every other day for 5 treatments. And so was that the same, and then they just did 4 more sessions, or what was the protocol that they followed for the plasma exchange?
Yeah, I mean, we follow a similar protocol. Our renal folks do it, and sometimes we're kind of at their, you have to collaborate with them with the timing of things. Sometimes it's imperfect. But we started to see a response, and so we continued it. Chantal, do you have anything to add to that?
Yeah, no, and it was every other day, the same as your protocol.
Yeah.
Yeah, 1 exchange every other day. For a total of 5 exchanges, and then, like Dr. Levin said, that they decided to extend it. We decided to extend it.
And that brings up another good point. And I find that it's regionally variable as to who uses plasma exchange and who doesn't. Is that something that's fairly routine in Canada, or is it regionally specific there as much as it is here in the U.S.?
I think it's regional. I'm not sure how often it was used before I got here. I use it a lot. I've seen some really nice responses, including this young lady and several others we've had, including one this week that may be showing some recovery. So I think there's enough, data, and I think Mayo presents it in the most thorough way that, unlike Mayo, we can't biopsy everyone before we do plasma exchange. But
yeah. You mean a wallet biopsy?
Right. Right. I can't. I've only been in Canada for a couple of years. I think it is regional. In the States, it was always about kind of payment and who is going to cooperate with you to get it done. Here, the renal guys have just been fantastic all over the province. I mean, you ask, and it's done. They get a line in 24 to 48 hours, and they're ready to go. Their preference is to keep the line in longer than I would like, but in case we want to do it again or give a longer string of exchanges, they'll try to keep the line in for as long as possible because they don't like to replace them if they don't have to. But at least in our area, we've been really fortunate. They've been exceptionally accommodating. And back to the natalizumab question, I think we've all learned that earlier is better, not to wait to let natalizumab completely lose its efficacy. For those people who've used B-cell depleters on natalizumab, have there been any complications from that, either an immunosuppression, infection, or anything else? Any comments on that?
No, I'm reluctant to say anything. That's superstitious.
This is Paula, and I'll answer that. This is Paula in Dallas, and with our experience of going from Tysabri to Ocrevus, we haven't had any. We have patients who have recurrent UTI, so I'll say outside of that, we haven't had any major infection problems with going on to a B-cell depleter.
Wow, that's great to hear. I'll throw out something, a topic for discussion I've been thinking about as I've been thinking about the case and rereading it. With all of the funding we've done with myelin-specific immune reactions and other things on the research side. Is alemtuzumab unmasking patients who have B-cell MS? Maybe MS is so variable because there's T-cell MS, CD4-8 MS, CD8 MS, and B-cell MS. And is this unmasking a phenotype? Patients who have B-cell dominant MS. And I just throw that out for discussion.
Boy, that's a great question, and I really think about that a lot. MS is really so phenotypically different, and you really would like to be able to have some sort of reliable biomarker to say, okay, well, this person's going to respond to this mechanism of action on a DMT versus another, and the fact that we have 15, 16 different FDA-approved DMTs with several different mechanisms of action and more on coming down the pike, that really leads me to believe that there can be these subtypes. And I think you're right. I think that, if you're using alemtuzumab, which has its own specific mechanism of action, maybe you are just not hitting the pathways that is inherent to that individual patient's pathophysiology for their MS. I think that's a great point. I'd be interested to hear what others think.
Yeah, Brian, this is John Kramer. I think you're absolutely right about that. And Mayo Clinic did a paper probably 20 years ago or longer now that talked about patients that had failed, who had, and actually it was a broad phenotype. It wasn't just MS, but patients with demyelinating disease unresponsive to corticosteroid therapy for relapses. Those patients seem to respond best to plasma exchange. And I think that is the perfect illustration of what happened with this particular case as well, that is more of a type 2 phenotype, if you will, from a pathological standpoint. If you look at Claudia Lucanetti's data out of Mayo. So it's clearly this patient responded really well to plasma exchange.
Yeah, I would have to agree with both John and Brian, your comments. We have a small set of patients who seem to be very great responders to plasmapheresis, and that we've actually decided just to keep them on getting Plex either every 2 weeks or every month as their DMT, because it seems like everything else, although they have not tried Ocrevus yet because the patient is just too scared to change to something else, but every other DMT we've exposed them to, they seem to do worse on it, but as soon as we put them on plasmapheresis, they seem to do better. So I would agree that there is, some type of truly a B-cell predominant MS.
I know, John, this is Jennifer again from Oklahoma City. I know, John, you brought this up in your email about the, the odd presentation with the enhancement there in the optic chiasm, and then, to me, when I was reading this case, the dramatic change in the patient's visual acuity, to suggest something that could be similar to MOG or NMO. And I do kind of wonder if we were to go back and look at those patients that we have that we, initially called MS because it fit the diagnostic criteria at the time, and we didn't have some of the more selective tests, specific tests that we have now, to wonder if maybe they are NMO or MOG spectrum disorder, and if we're really, reevaluating those patients now that we have these tests available to us.
Which brings up an interesting point, and we have some folks who for all intents and purposes look like NMO, but their antibody test comes back negative, so we call them NMO spectrum disorder, but maybe they have some other funny white spots in the brain that could be MS-like, and what do? Well, we treat them with rituximab anyway. So I guess, we sort of are trying to hedge our bet and cover it, and by saying, well, it's probably rituximab would probably work with both cases, so maybe we can do that. I don't know if anybody else has these quasi cases that don't really stratify into one camp or another, and what they do with them.
Fox, just sorry, I was unable to dial in for a little bit. But Brian, we had the same situation. If it kind of smells and looks like NMO, even though there are NMO titers and they're anti-MOGs are negative, we will treat them with Rituxan, and they do fairly well. I have a question. I'm sorry I joined a little bit late, and I might have missed a few questions around the Plex a little bit more. Do most of you treat with Plex in patients that have rebounded with Lemtrada, just in generality? Or are you all switching mostly to Ocrevus?
We are switching to Ocrevus. I think at the time in our province, neither, Ocrevus had not yet been approved, and there were barriers to rituximab, so our hand was forced a bit. But yeah, I still think, we would have treated this as an acute relapse and probably got her on a B-cell depleting therapy as soon as possible. If that was available at the time, and it's available now, but it wasn't available at the time of the case. But I still think we probably would have treated the acute part the same while waiting to get a B-cell depleter. I don't know if other people have other thoughts on that.
Well, at our center, we haven't had many patients at all have any type of rebound post-alemtuzumab. We had one or two patients that I can think of after their second round that we're calling it a relapse, and so we just opted to treat them with a third round of alemtuzumab, and just said it was just your typical inflammatory breakthrough, not necessarily a rebound effect from alemtuzumab.
Yeah, we've had a very similar experience with our Lemtrada patients where we've chosen to do a third cycle, actually not due to a clinical manifestation of a relapse in terms of neurologic deficits, more just radiologic changes with the development of new enhancing lesions where we've chosen to do a third round and in one or two cases a fourth round. And then in some of those patients, we've gone ahead and switched them over to Ocrevus. But we've not actually had someone with presenting with new neurologic deficits consistent with the relapse in that regard, just the radiologic changes that we've seen on MRI.
Anybody want to follow up?
Yeah, so I think that brings up another good question, and that is, what do folks do for monitoring? We generally will repeat neuroimaging on a regular basis, but does anybody really track flow cytometry to look at B and T cell function in these folks, or any other particular lab metrics that folks do on a regular basis to monitor from a lab standpoint?
Not routinely. When I was learning how to use rituximab, I followed absolute B-cell count, kind of beginning at month 9, and then redosed. But that was before we knew all about it and the other meds. But for alemtuzumab, we don't do it routinely. I think we did it on this young lady a couple times after our first experience with it.
So it's interesting. We have a patient currently right now that we're in this exact same situation over in our center, and I probably, and we haven't done this yet, but I feel like I'm going to follow her serum immunoglobulins a little bit more closely, just because of the confounding factors for an infectious process. But that's just something I've been thinking about, but I haven't done it quite yet.
John or Paula, do you guys do anything in particular?
Nothing. I mean, we do follow CD4, CD8 for our patients post alemtuzumab. Is that what you were asking a reference to, or?
Yeah.
Yeah. So we do the recommended, and then also just the following the CD4, CD8. We're not routinely getting a CD19 count. But, it's definitely something to keep in mind. We've inherited a few patients who have had some of these rebounds on alemtuzumab, and at that point we'll check CD19 counts, but if I remember correctly, most have still been somewhat depleted, so we haven't really viewed them as rebounds.
Well, I flipped over to the next slide because I thought it was quite interesting when we're talking about variability in monitoring and then treatments and so forth. You all provided this really nice summary of the case reports and the literature to date with regard to the different cases and what was done or maybe what wasn't done. And I thought that it was interesting that out of the 16 cases, not including the one that you were presenting, about 10 of them didn't have any type of a therapy with regard to their quote-unquote relapse, and I thought that was interesting. I think that when we start to go back to, okay, well, what's the utilization of Plex or high-dose steroids and so forth, and there can be some regional differences. One of the other questions I get a lot of times is with regard to steroid treatment. Certainly, we use primarily what we use based off of the optic neuritis treatment trials with regard to the high-dose IV Solu-Medrol, and there's some plus and minuses to doing oral steroids either instead of high-dose oral steroids instead of, or doing steroid tapers to follow. And I'd just like to get the group's input as to what folks do. Do you use oral tapers after IV high-dose Solu-Medrol, or do you not, or is it sort of dealer's choice? Not to make a pun since I'm in Vegas, but
We typically at our center in Dallas, we do not do a steroid taper after the high dose. We'll either do a high dose oral with Decadron, or sometimes we'll do the Prednisone, or we'll do the IV Solu-Medrol. Unless the patient truly describes some type of withdrawal from the high doses, then we will put those on a taper. But customarily, we do not taper afterwards.
It's Lisa. We do the same.
That's the same here for us in Oklahoma City. I've been a fan here lately of doing the high-dose oral prednisone just because of the convenience and not having to, figure out where they're going to get their infusion or setting it up through home health. And typically it's tolerated remarkably well, like better than I would have thought, without having to do a follow-up taper after the 3 to 5 day course of the high-dose oral prednisone.
Do you have to get that compounded, or do you just use the available dosing and you just have them sort of take a fistful of pills?
Yeah,
we
so
do
exactly
20. It's a 50 milligram prednisone, so we'll do 25 tablets and split it up between 13 tablets in the morning and 12 tablets later on in the day. And that's been working pretty well. We'll have some folks get some Pepcid if they need it for any kind of heartburn that they might have. But it's all, I always have to talk with the pharmacist, sometimes multiple times, because they're convinced it's a mistake when I order that much prednisone at one time, because it only comes in a 50 milligram tablets. But I e-scribe it, and then I do a follow-up call with the pharmacist, and between those two things, I'm usually able to get it pretty quickly for the patient.
No, we're the same way. It's the Prednisone 50, and then on my e-scribe prescription, I have started writing the dosage is correct. And so that has helped eliminate a lot of the additional phone calls from the pharmacist.
Yeah, I also do the same. I would say this is the equivalent oral dose to IV. That's always helpful too. I have found though that I see a little bit more increased bone pain with the oral dosing compared to the IV dosing.
Also, for modest size spinal cord lesions, or most spinal cord lesions, I tend to taper. So, the thinking's going back and forth. I think when I trained as a resident, we tapered the optic neuritis treatment trial was a taper, and then we found that we didn't need to taper, and I got burned a couple times, not terribly, just spinal cord symptoms came back, and so for significant spinal cord lesions, either clinically or by MRI, I tend to taper those, and others we do not. We kind of take a wait-and-see approach. But we still have more patients that we'd like kind of have that really ugly withdrawal episode experience. So we kind of mark that in the chart now. If that happens to them once, then the second time we give them a taper.
Well, one other question that I had, sort of switching topics, is the comment that you had made in the paper alluding to not really being able to have access to rituximab. Is that a formulary thing? Was it a supply issue? What sort of barriers were you running into with regard to using rituximab?
It's since been resolved. I think it was for a short period. So Saskatchewan's a unique place. There hadn't been specialists, or at least neurology-trained specialists in MS since Ilya Polakov and I got here about 2.5 years ago. And I think there was some miscommunication between clinicians and the pharmacy board that approves these kinds of things. And so, I mean, it's something that resolved soon thereafter, right, Chantal?
Yeah.
Did you want to comment on that?
It's the formulary coverage that
okay.
that we didn't have, but now we do have that coverage. So, yeah.
One of the other things, I think it was maybe Paula who had brought this variable in the equation up earlier, was when transitioning patients from one DMT to another, say in a case such as this, for whatever reason having to come off of natalizumab and switching to another DMT, how much of a barrier do folks run into with regard to patient preference, knowing that we do have a fairly wide landscape of therapeutic options with a number of different delivery routes? Are folks having patients say, hey, no, I want X versus I want Y, or are you sort of driving the boat a little bit more with regard to decision making and directed decision making with the option of what to switch to from natalizumab? I'd like to open that one up.
Hi guys, it's Lisa. I'll take this one a little bit. I find what I tend to do is I talk to them about the mechanism of action. I look back on their prognostic indicators, and I kind of streamlined it down to 2 options, and then based on laboratory values such as JCV, what their history is, how old they are, and then kind of cater it and lean them towards one drug for the most part, but I do end up ultimately giving them 2 options and to explain why between the 2.
Yeah, I liken that to the toddler paradigm. You don't open up a closet and ask the toddler what they want to wear. You pull out the red shirt or the blue shirt, and you ask them, do you want to wear the red shirt or the blue shirt? So I'm interested to find anybody else's take on that.
This is Paula. Go ahead, John. Or
sorry. Yeah, no, Brian, that's a great point. I think gone are the days of handing someone 5 or 6 different binders and telling them to go home and assume they're somehow the expert to pick the disease-modifying therapy of choice. So your toddler analogy is well said.
Yeah, I agree. Many times patients will say that they come to me for my expert advice, and while I appreciate that, I also know I have to get their buy-in for whatever drug. And so I take the same approach of looking at previous therapies they've been on, what changes are they having, and say, these are the two I think would be the best options, and use very persuasive language to hopefully get them to see the one I really want them to go to, but definitely explain, both would be viable options.
This is Jennifer in Oklahoma City. Yeah, we do very much the same, where we really try to narrow it down. But one of the things, if I get a patient that wants medication and they specifically ask for it by name, even if it is something that I think, hey, that would be a great option, we should go to that. One of the things I do is I want to get a good understanding of what their expectations of the drug would be, because sometimes their expectations are not realistic versus what they've heard from their neighbor, from Facebook, from any of these sources. And so, my biggest fear is that we switch medications and then, a year later they're upset because they're not getting any better. And, the goal of the medication is to keep things from getting worse. And we would all hope for better, but, that's not very realistic when you're looking at somebody that's been in perhaps a wheelchair for 5 years and they want to start walking again because that's what their neighbor down the street's cousin did after they got 2 doses of whatever medication. So that's another conversation that I try to have with my folks.
Yeah, that's a great point. Level setting expectations. Talking about, well, let's get you through this hurdle if they're having an active clinical and radiographic relapse, and then what do you do from there? I had a patient recently who was coming in just for a routine follow-up, and she had a routine MRI scan done that morning, and when I looked at the scan, I was like, oh my gosh, what's going on here? I was kind of hesitant to poke my head in the door because she had several new and enhancing lesions, and I kind of opened up the door a little bit, poked my head in and said, hey, how you doing? And, she's sitting there happy as a clam and waved at me and said, hi, how are you? And so I had to go back out in the hallway and look at the MRI scan again and make sure that it was the right patient. And so, she really wasn't symptomatic at all. And her exam was fairly non-focal and certainly wasn't too much different than her baseline. And we had to have a conversation at that point, well, do we even need to use steroids, and what are we treating? Are we treating the patient? Are we treating the scan? What are we doing? And so I think that's the first step if they are having either a clinical or radiographic relapse, is to figure out what you want to do at that point, but then have that discussion about, well, if we need to switch a disease-modifying therapy, number one, what are we hoping to gain from it? And number two, how are we going to do it?
Michael, he was in the playpen when I came home, by the way.
Brian, I hear you on those. You're always curious about how the patient's reacting and how they're doing, because you're never sure with that many enhancing lesions. May I ask a question?
No.
I'm doing it anyway.
As I know you would, Lisa. As I know you would.
If you guys have patients that are stable in Tysabri, the JC virus negative, and all of a sudden their JCV goes to high titer positive, are you obviously doing an MRI, but are you recommending an LP on these individuals that go quickly from a negative to high titer?
So routinely, we are not. This is a conversation one of the nurse practitioners in our clinic has been bringing up of, shouldn't we really, make sure nothing else is going on? And so, yeah, we're having that same debate within our clinic. Currently, we're not really doing the LPs, part of it because it's just a coordination nightmare in my institution to get done. But it is an ongoing conversation we are having in our clinic.
The first thing that I do is I repeat the anti-JC virus antibody index to make sure that that's actually the case. Maybe it was about 2 years ago now, we had a run of folks who were coming back unusually high. And so I always get a little concerned when something really big changes. So it's sort of the old idiom of repeat the blood work until it's normal. So the first thing I'll do is I'll repeat it just to see if it's actually true or not, and then kind of go from there. So I've got not a political question, but more of a healthcare landscape question, and that is, what do you sort of see as the differences between how folks approach or are treated with MS in the U.S. versus Canada, given that you've been in Canada for the past 2 years now? Is there significant differences with the approach, or is it differences with regard to formularies? I know that each province is sort of its own entity. Can you maybe comment a little bit on that?
Sure. So in the States, I was in the private sector for a while, and then a VA, and I kind of have a feel for those two organizations. And here in Canada, and again, just like the States, I think there are regional differences. We're in the middle of the country in a modest-sized city, and things might be different in bigger cities. I think from a practice point of view, it took a little bit of time for me to get used to the system. It's somewhere between private practice and the VA here in Canada. Again, it's universal health care, not socialized medicine. There's a robust private practice here and throughout the country. I think in the States, I was more likely to choose a medicine that I thought fit a person's MS and their phenotype. Here, we do have to go through, do I call it stepwise or whatever? Yeah, I mean, here you're supposed to use certain meds first and then try others, and that varies from province to province. But I didn't really find that problematic because the barrier to starting a second medicine, if the first medicine didn't work for either side effects of efficacy, is actually quite low. In general, I think it's easier in our province to get medications and to get them mostly completely paid for. And Chantel's here, and she does a lot of that work on behalf of our patients, so I want to give that to her in just a minute. But overall, it's been a really positive experience practicing here. There is infrastructure to take care of patients. We need more docs and healthcare providers like anyone else. Like I think any other MS clinic that's growing, our wait list is longer than we'd like. But I think once you're diagnosed here and put on a med, it's fairly easy to maintain that med and to switch. So I think that's the short story. Now I'm going to have Chantel comment a little bit on reimbursement.
Yeah, so how the reimbursement process works is we have like the first line medications, so those would be the interferons, glitiramer, Tecfidera, and Ocrevus. Those are the first line medications. So you pretty much just have to have a diagnosis and a relapse or new MRI activity within 2 years. And you would qualify for any of those medications. And as far as coverage, once you qualify, the province covers, we usually say around 80% of the cost of the medication, and then patients' private insurance would supplement that if they have private insurance. If they don't have private insurance, then often the drug company will provide some sort of bridging for those patients. And then in order to qualify for a second-line medication, which would be like alemtuzumab, Gilenya, Tysabri, it just varies a little bit with each of those medications. And I don't have the exact criteria in front of me right now, but it's usually, if they've had new MRI activity or a relapse, then they would usually qualify for one of those second-line medications, and the coverage would be the same.
If you felt really strongly from the beginning that a patient needed to be on one of those like second-line medications, is there an avenue where you can go to sort of plead your case to try to get that waivers or something?
Yeah, so the only two that we could probably do that with would be Tysabri or Gilenya, and that would be through the drug company providing coverage. They have to, in order for the province to cover, they have to meet those specific criteria that they have set out.
Is Mavenclad?
Mavenclad, it's not actually covered right now by the province, so that's also all through the drug company, like the patient support programs, the bridging that they offer.
I'm glad somebody brought up Mavenclad because our U.S. EMD Serono people here are claiming that the trajectory of that medication in terms of prescribing habits is on a rocket ship in Canada. I'm just curious what both of your thoughts are on that comment, because here in the United States it's been a very soft launch to say the least.
Yeah, I think it's down to the individual. I don't personally use it all that often. My partner uses it more often than I do, and I think you're right. I think nationwide there's been enthusiasm for it, and I'm not sure whether those folks were in clinical trials or had a comfort level with it before it was approved. But I think it is regional and down to the practitioner, and there's differences in my thinking about it and my partner's thinking about it. Chantal, do you have any insight into that from the meetings you've been to?
Not a whole bunch. I guess, sometimes where we find that it's good is for patients with family planning, because we can get them on it quickly, they're done their treatment and can plan to get pregnant in 18 months after their first dose. So I would see that's where we see it. Also, if patients don't qualify for a second-line medication, I've seen, it used in that situation as well.
We have a couple of other barriers here in the U.S. with a lot of private insurers now moving away from covering infusible services at hospital-based infusion centers. And if your institution is basically tied to a hospital-based infusion center, well, that sort of ties your hands. And you would have to figure out a partnership with a community-based infusion center, or maybe the institution that you're working with has made provisions to have a non-hospital-based infusion center. But this is becoming more and more of a difficulty from a payer perspective with regard to the infusibles. So it'll be interesting to see, what that landscape looks like in the future when we're going to have maybe a few other medications that will be coming out that aren't IV deliverables. What does that landscape look like, and how does that change prescribing habits, based on some of these issues? But it's interesting times that we live in, and I think that in some regards it's great to be in the position that we are in currently, having the options that we do have, as opposed to in the early 90s when we really didn't have these options. We're coming up towards the top of the hour, so I wanted to, certainly thank our authors, and I really want to extend a special thank you for everybody who's joined us on the program tonight. Like I said, this is our inaugural program, and we're hoping to do more of these. Certainly, I would encourage folks, if you still have questions, you can still respond to the online thread that was out there. Those are still going to be collected and looked at for a little while, but those are options for you. and like I said, we're going to get an email out to participants in the next few days with regards to instructions on claiming CE credit. But before we wrap things up, I just wanted to ask anybody if they had any other questions or comments that they'd like to interject before we wrap up. I think, one of the other asks that I have is that as we're doing this, if you have suggestions for articles, we're doing this for you. We're doing this for everybody. We're doing this for us. And I want this to be value added because we're all taking time out of our personal lives and in our work lives and so forth. So I want this to be value added. So if you have a suggestion for an article, please let us know. But before we end, I just wanted to open up if there are any other questions or comments.
No, but I wanted to say thank you.
And I want to thank the organizers for this and choosing our article. It's been, it's been an honor to be chosen for the first article and an excellent learning experience. And we look forward to participating in future ones.
And I'd like to second that. Thank you.
Absolutely. We won't discriminate to our colleagues towards the north.
Right.
Well, great. At this time, I don't know if Roya, our host, has any additional comments, suggestions, instructions, or if we're just going to close this out, then we can close it out.
Excellent. Sir, if you have any additional closing remarks at this time? No? Okay. Thank you. This will conclude our conference for this evening. You may disconnect your lines at this time. Thank you for your participation. Have a wonderful night.